Uh, all right, thank you so much for inviting me to speak here. I'm actually very excited to be here with this group from many different backgrounds. I will just say, apropos of the introduction around data and all the cool data the NIH and NSF are collecting and making available, I have been working with the All of Us dataset, and it is pretty awesome. And I strongly recommend others consider using it if I can give my own personal experience. I'm also a participant in the study. I signed up to give them my data because I thought it was so cool. So you can get my own data as well if that's any appeal. Okay, great. So today I'm going to be talking about using machine learning to increase equity in healthcare and public health. Broadly, my research pursues two paths to doing this. The first is around debiasing decision-making. How do we make decision-making fairer, both in healthcare and more broadly, both human and algorithmic? And that's encompassed work on sort of policing, on pain, on many other domains. The second broad thread is around understanding the health of understudied populations, and that's involved, for example, studying COVID and women's health and other things like this. Today I'm going to be talking specifically about that first direction, about sort of understanding bias in decision making. And one thing you see in analyses of bias is that most of them rely on three key ingredients, which I'll just introduce here. One is sort of the outcome we'd like to study, like was the patient allocated a health service, or did they survive, or things like this. The second is what I'll call the features, or you might hear referred to as the covariates. And those are things we'd like to sort of control for contextual information, like the patient's medical record. And then the final thing is the patient's sensitive attribute. This would mean something like gender or race or another dimension along which we wish to assess disparities. And so, for example, we might do a regression where we regress y on x plus a, and then we look at the coefficient on a. That would be a very sort of classical econometrics or health services thing to do. More recently, in algorithmic fairness, we might estimate some predictor y hat, which seeks to predict the outcome y. Y hat would be a function of the sensitive attribute in the observed data, and then we would assess various properties of y hat, like its AUC or other things like this. And so in this talk, I'm going to discuss how do we assess and avoid bias when we have missing and noisy data in all three of these things. I'll tell you three separate stories, the third only very briefly. And the reason this is an important question is because, as you all know, having worked with health data, missing and noisy and generally imperfect data is ubiquitous. It is a fact of life. It is inescapable. And therefore, it's very important to account for in our AI and statistical methods. So let's jump right into it. Let's talk about missing data in X and the consequences for whether we should use race in clinical algorithm predictions. This is very relevant, as many of you will know, to recent discussions in the medical community, as I'll discuss in more detail. And it's a working paper, joint work led by Anna Zink and with Ziad Obermeyer. So, as you may know, there's been sort of a high-profile debate in the medical community around when we should use what are called race corrections, the use of race in clinical algorithms, and this has immediate consequences for patient care. So it's not just something which is appearing in like the New England Journal of Medicine or whatever. It's something where there are congressional requests for additional information. Their like clinical systems are right now changing the way they run their algorithms and treat patients. So to give a specific example of this, you could look at estimated glomerular filtration rate, which is an important measure of kidney function. And what I've shown you on the left is a screenshot from the widely used tool MD-Calc, which clinicians use to sort of compute various clinical measures. And you can see basically, depending on whether the clinician enters that the patient is Black, they may get a different answer for this estimation of GFR. And this has important downstream implications for how the patient is treated, like whether they're diagnosed with kidney disease, what doses of drugs they get, kidney transplant eligibility, like all these things. Like basically, whether or not you include this variable, like shifts your decisions potentially about a bunch of important downstream outcomes. But this isn't just occurring in nephrology, it's happening in many other domains as well, cardiology, obstetrics, et cetera. And there's a nice paper in the New England Journal of Medicine a couple of years ago, sort of providing an overview of many of these contexts. And to be clear, there are very good reasons for this scrutiny. I'll just give you three. One is that just like from a purely like statistical empirical point of view, many of these race corrections have been based on quite sketchy, dubious empirical data, small samples, biased samples, outdated samples, like whatever, like even on the pure grounds of like doing pure statistics, you would want to take another look at many of these. Now, you might also have concerns, and many people do, about exacerbating health disparities. To give a concrete example, if your algorithm, because of the race correction, predicts that Black patients are at lower risk of cancer, then you might in turn be less likely to recommend them for cancer screens. And this could exacerbate already existing disparities in access to cancer screening. So we might have concerns about, if we include race as a predictor, will it exacerbate existing health disparities? And then finally, there's a long bad history of racist false beliefs about biological racial differences, sort of treating race as a biological variable when in fact it is a social construct. So two specific examples of this would be, for example, the long-standing belief that Black patients required higher doses of X-rays, which is obviously dangerous for patients. Similarly, there's been a widespread false belief among clinicians, among others, in differences in pain perception between Black and white patients. At the same time, while there are very good reasons for this scrutiny, the consequences of removing race from algorithms remains unclear. And obviously, removing predictors in clinical algorithms with these really high stakes is something that you want to do carefully. And, consistent with this, there's been a call or a number of calls for people basically saying we should be cautious, we should be careful, we should refrain from haphazardly removing race as a predictor. So how does this intersect with missing data and with imperfect data? The argument we make in this paper is that removing race as a predictor can have unintended consequences and even potentially decrease equity. And we're going to present a specific case where this occurs when racial bias creates a differential measurement error. So what do I mean by measurement error? Basically, what I mean is that racial bias can make it more likely that some race groups will have important risk predictors mismeasured. And there are many, 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 many examples of this. We, wrote a review paper cataloging some of them a couple years back. Disparities in testing, disparities in diagnosis, disparities in whether a patient has medical records at all. Like the quality of medical data sort of reliably varies across sort of racial, socioeconomic, other contexts, right? So the specific predictor we're going to focus on here is family history, and we do so for two reasons. The first is that it is a critical risk predictor, right? If you go to the doctor for a mammogram, you're reliably going to be asked, do you have a family history of breast cancer? But the other reason is that there's a lot of previous work suggesting that family history is more likely to be mismeasured in some race groups. We know, for example, that clinicians are less likely to ask non-white patients about family history, and non-white patients may have higher rates of unknown family history. So for multiple reasons, there's mismeasurement here where reported family history may not be equal to true family history. So what are the consequences of this for risk prediction? Well, we study them empirically in a data set called the SCCS, which is a widely used study established in the early 2000s to study health disparities. And the specific question we look at is, how does colorectal cancer risk vary as a function of race and self-reported family history? And the main results in the paper is pretty simple, and it comes out of just two graphs. Here's the first graph. Basically, what I'm plotting here is, on the x-axis is age, stratifying results by age, because of course it's a very important factor for cancer risk. On the y-axis is colorectal cancer risk, and then we're stratifying by whether the patient has reported family history. And you can see that for white patients, reported family history is strongly predictive, right? There's a clear gap between the two lines. In contrast, if you look at Black patients, you no longer see a significant predictive relationship. The lines are basically on top of each other. Now, what might do this, a very, very consistent story with this is differential mismeasurement of family history across race groups. You might call this regression dilution or regression attenuation in the statistics literature. Basically, if you do the regression of cancer risk on family history, but your measurement of family history is imperfect, that's going to squash your coefficient on family history towards zero. And the sort of intuition for this is like, imagine that family history is perfectly measured, then the coefficient on family history will be the true coefficient. If, on the other hand, it's totally randomly measured, like it's just pure noise, the coefficient on it will be zero. And in between those two extremes, you get this interpolation, right? So if we want to capture those differential coefficients, the natural way to do so is with an interaction term between family history and race. And indeed, that is statistically significant. Okay. Now, you might say, okay, fine, like, maybe inclusion of race, like, nominally improves prediction, but nonetheless, like, what about its effect on disparities? What about its effect on equity? Are you, for example, doing exactly what you warned us about at the beginning of the talk, where you rate Black patients as lower risk as a consequence of inclusion of race, and thereby potentially decrease their access to screening? As it turns out, exactly the opposite is true. Including race rates more Black patients as higher risk. It increases the fraction of Black patients among the high-risk group, as this graph shows. So this could potentially increase equity and access to screening if, by rating them as high risk, you thereby make them eligible for screens that they would not have been eligible using a race-blind predictor. Okay, so to summarize this story, what I've told you, the scrutiny of the use of race in clinical algorithms is very much justified and indeed long overdue. At the same time, removing race in some contexts can have unintended consequences, in this case, potentially decreasing equity, and we illustrate this through a case study of the mismeasurement of family history. I want to briefly highlight a related point, not the same point, but also important to this debate, I think, which is that even if you remove race from an algorithm, the algorithm may end up reconstructing it anyway through proxies. And here's a disturbing example, which appeared last year in Lancet Digital Health, where the authors showed basically that a computer vision model could predict a patient's self-reported race from their chest X-ray, even under sort of substantial distortions of the image. And furthermore, the authors couldn't really figure out why, in spite of like a lot of very detailed and careful forensic work. So like this should be a worrisome result to you for many reasons, including like the limitations of our interpretability methods. But certainly it suggests, consistent with a bunch of other work, that just because race is not included in the algorithm is no guarantee the algorithm won't reconstruct it anyway. Okay, so to conclude this part of the talk, we don't believe that the solution to racial bias in clinical algorithms will come merely from excluding race, both because, as we show, this can potentially decrease equity, but also because algorithms can often reconstruct race anyway. At the same time, while we show that race correction can help capture differences in data quality across groups, we also think it's imperative to simultaneously pursue non-algorithmic fixes to these systemic data issues. We live in a world whose continuing deep structural injustices in healthcare and more broadly mean that basic critical inputs to our medical algorithms, like family history, are more likely to be missing or misrecorded for some racial groups. And I think we do a disservice to patients if we fail to acknowledge that reality in our algorithms. At the same time, acknowledging that reality is not the same as accepting it. While race corrections in algorithms can allow us to accurately capture deficiencies in medical data as it currently exists, it's important also to look beyond that to what medical data could be and needs to be if we are to, in the long term, achieve health equity for all patients. All right. I want to talk about the second story, and this is about missing and imperfect data in A, which you recall as the sensitive attribute. So in this case, A is race. And this is a working paper led by Raj Mova and Divya Shanmugam, and then with many other excellent co-authors. Okay, so as you all know, race data in US health records is often quite bad. In many cases, it doesn't exist at all. If it does exist, it may have high rates of missingness. And the problem we study in this paper specifically is also, when it does exist, it typically lumps together what I'll refer to as granular groups into coarse race groups. So for example, both Indian and Chinese patients may be grouped together as Asian. And just like intuitively, right, this seems risky. It's like clear from health disparities research, for example, that these subpopulations have important health differences. What remains unknown, however, is whether this coarse race coding conceals disparities in clinical algorithm performance. So that's exactly the question we study in this paper. Specifically, we leverage newly released granular race data in the MIMIC data set. This really just came out a couple months ago, I think, to ask two questions. First, are there granular disparities in clinical risk score performance? And second, if so, why? So the data is, a couple 100,000 ED visits from MIMIC-4, and what we look at are 5 predictive risk scores. So 3 of them are ones we fit ourselves to predict 3 common outcomes in this context: hospitalization, what we refer to as critical outcomes, and revisit to the ED. Very, very simple models, by the way. We're just using logit regression models, no fancy machine learning here. And then we also look at 2 previously developed risk scores in the medical literature. We look at disparities in 4 different measures of algorithmic performance. If you paid attention to the debate in algorithmic fairness over the past few years, you'll know that there's been an enormous proliferation of fairness definitions, things you want to equalize. We don't want to get into that debate. We just look at all the things. If there's a thing we haven't looked at that you'd like us to look at, it's possible we've looked at it since this draft initially came out, but we don't want to take it. Basically, we just want to look at all the measures. Okay. Here's sort of an overview of the patient counts in our data set. And so this illustrates what I mean by coarse groups and granular groups. We look at 4 coarse groups: Asian, Black, White, and Hispanic / Latino. And then each coarse group has granular groups which nest within it. You may notice that some of these granular groups have an asterisk on them. That refers to patients who, for example, marked their race only as Asian and did not provide a more granular, a more specific grouping, and we include them in our analysis because they're an important patient subpopulation in their own right. Now, you may have various issues with this table, and I probably agree with all of them. For example, you might ask, like, who determined that mapping of granular groups to coarse groups? Or you might say, these aren't all properly described as race groups. Some of them might be described as nationality or country of origin, for example. You might also say, you know, why do we have this particular set of groups here? Basically, I agree with all those objections. We worked with the data as it was recorded in the medical data and followed their mapping of granular to coarse groups. But the fact that this mapping is messy and imperfect is sort of exactly the point we're trying to highlight here, that like if you study it by this very sort of crude coarse fashion, you're going to miss important things. Okay, so I'll show you the results. So here what I'm showing you is just like one measure, one outcome. I'll show you the results for everything in a second, but this is just to build intuition. And you know, I'm just breaking it down for you now by course group. And you can see, you know, there are some disparities by course group. But just looking at it by course group really conceals, you know, substantial granular disparities. You know, you can see there's a lot of variation, which isn't just captured by those vertical lines. And I should say, by the way, that generally this paper is pretty methodologically straightforward. One thing it's really important to do right, though, is to quantify uncertainty correctly, and in particular, you know, sort of conservatively, and because otherwise you're going to see sort of disparities where there are none. Happy to chat more offline about how we did that. Okay. You know, this basic result that sort of looking only at the coarse race level conceals granular disparities is consistent across groups, it's consistent across metrics, it's consistent across outcomes. Very, very consistently, we show this result. And so the statistical significance stars here indicate that at least one granular group has significantly different predicted performance than the coarse group after multiple hypothesis correction. You might say, well, maybe it's statistically significant, but like, is it actually practically significant? Doesn't matter. One comparison you might do to assess this is say, how does the magnitude of the variation between coarse groups, in other words, across white, Black, Hispanic, Asian, compare to the variation within coarse groups? And the reason this might be an interesting comparison is that the between coarse groups is basically what every algorithmic fairness paper in medicine looks at, due simply to lack of data, right? They can only look at the coarse group level. And so what we find basically is that the magnitudes of these two types of variation are quite comparable. In other words, the magnitude of the variation, which is entirely concealed by coarse race data, is comparable to that, which you sort of conventionally study in algorithmic fairness. Why? We put a fair bit of time into this in the paper. I'll only summarize it briefly now. It's not just base rate disparities, which might be your instinct if you've sort of worked in this area, although this is part of it, nor is it just differences in sample size. Rather, we sort of document that literally all aspects of the data distributions differ across groups. So the distribution of the symptoms, the distribution of the outcomes conditional on symptoms, the distribution of the outcomes, all of these things show statistically significant differences. And furthermore, often quite fascinating differences in ways which are consistent with the prior literature on health disparities. So that's interesting as well. The sort of widespread pervasiveness of differences in the data distribution suggests that you might see disparities in other risk scores as well. So what are the implications? We think this has some important implications, particularly in light, by the way, of the fact that the government is actually currently considering recoding how they do some you know, race collection of race data in census data. We think one implication is that it's important for health data providers to try to collect and analyze granular race data, not just coarse data. Because existing analyses have largely only been able to work with coarse data, it's possible that they understate or even entirely obscure disparities in clinical risk score performance, which would emerge if you could look at the granular level. And less relevant to this talk, but we think it's plausible that you could see similar effects in terms of algorithmic disparities in other domains as well, for example, social science domains. Okay. Final story, I'll only tell you this very briefly, but I did want to highlight it. This is joint work with Divya Shanmugam and then with William Howe, and it's about quantifying inequality in underreported medical conditions. So the goal of this paper is to assess the relative prevalence of underreported conditions. What do I mean by relative prevalence? This is basically how much more common is a disease in one group versus another group. So for example, in women versus men. And if you perfectly observe the disease, if you perfectly observe that Y, this would be easy to do. In this example, for example, 2/3 of women have it, 1/3 of men have it. So you just do 2/3 over 1/3. That's 2. Great, we're done. But this is much more challenging if the condition is underdiagnosed in a way which varies by group, right? Now, as this diagram shows, you have differential underdiagnosis across the two groups, more so in women. And so if you simply take the ratio of observed diagnosis, you'll see that the disease is equally common in both groups, entirely obscuring the disparity that you would observe if you could actually look at it at the ground truth, which is unavailable. Not going to tell you how we solve this problem at all. I'll simply tell you that we do come up with a statistical solution to it, which draws on positive unlabeled learning, which is a common formalism for modeling underdiagnosis. We then apply it to study the relative prevalence of intimate partner violence, which is the condition that originally motivated this work. It's a very underreported condition. It's a differentially underreported condition. And so what we do is we apply our method to show that IPV is more prevalent among patients who are on Medicaid, who are non-white, who are not legally married, who are in lower income zip codes, and who are in metropolitan counties. We assess this in 2 different samples. We look at MIMIC, but we also look at NEDS. And overall, we think this analysis contributes to the literature on IPV disparities because it uses large and recent samples, it evaluates robustness across multiple data sets, and importantly, it corrects for underreporting. We think that there are other settings where you could apply this statistical method as well because underreporting is so pervasive in medicine. Okay, I was asked to speak briefly about what I think are important future questions in this area, so I'll close the talk by doing that. So I think, so first, future questions in health equity, which I think are pressing are, first of all, I view this as a very open question. We're going to have missing and noisy health data, and that has profound implications for equity, as hopefully this talk has convinced you, for a long time. And we need to continue to think about how to train equitable models in the presence of missing and noisy health data. Concurrently with that, I think we need to think about how we improve data collection, and certainly the first 2 stories are relevant to that. Secondly, it's become, of course, a cliche to talk about LLMs, but I have to say I am very excited about their potential to improve health equity. As mentioned at the beginning of the talk, there's a lot of concerns about LLMs and how they could increase inequality, certainly, through the presence of biases, through the, consolidation of power to a few large actors. At the same time, though, I think there are, really exciting potential implications of the, applications of these tools for good. And I'm very interested in projects in that regard, not just the sort of, how do we criticize these tools, which I think is a very important line of work, but also how do we use them more positively to improve health outcomes for underserved populations. In ML for health writ large, I would say the questions I'm interested in most fall broadly within the area of how do we bridge the gap between performing well on retrospective data sets and actually helping real patients. Some questions which I think are relevant to that include how do we deal with the human in the loop, how the sort of interaction between the doctor and the algorithm. How do we make these models more interpretable so we're actually sort of comfortable using them? For example, I think the prediction of race in a way that we cannot really understand is, to me, makes me pretty nervous. How do we make these models sort of robust across, temporal distribution shifts across different hospitals, et cetera? And then finally, just on a purely practical level, how do we make it easier to actually not just work on the MIMIC data set, but sort of close the full pipeline of, we've trained a model and we're actually deploying it in a real population. So these are some of the questions which are exciting to me, and I'm very much looking forward to the ensuing conversation. Thank you.